Okay, Megan, you want to go for it?
Yeah, absolutely. Good morning, everyone. Thanks for joining us. This is Megan at CFILC. And I just want to get started with logistics of Zoom. I know we're all pretty familiar with it at this point. I think these Disaster Strategies Coalition meetings always have captions available on our second and fourth Tuesdays. You can access captions in Zoom if you go down to your toolbar and look for the CC caption button. If you don't see that, it's probably nested under the More button, which is those three dots, the ellipses. When you click on that, you're going to look for the option that says Show Subtitle. We also have captions available on Stream Text, and I just shared that link in the chat. Please go ahead and mute your microphones while you're not speaking, just so we can help with the call quality. And I know Sylvia has lots of time for discussion, it's a small group here, so I think we'll have a good conversation. Let me go ahead and pass it back to you, Jin.
Hey, thanks, Megan. Well, welcome. I'm June Tales. I'm a disability policy consultant in Los Angeles and a contractor with CFILC's California Disaster Coalition and helping to put together these calls. So I have COVID graying hair, and COVID reminds me, this hair reminds me that I'm older than I think I am. So every time I see it, I go, what happened here? Anyways, I have a blue sweater on, yellow turtleneck, and glasses, and I have colorful wallpaper of people wearing a variety of masks in back of me. So as we wait for others to hop on, just a reminder, we've got some future calls lined up. Next month on March 11th, we'll be hearing about what it takes to help people with disabilities really put together quality and real personal preparedness plans. So that's on the schedule. And in the planning mode, we have calls. We're planning on homelessness and disability, which also involves Project Room Key, the Home Key, COVID-19, the cooling and warming centers for people who are homeless, personal assistance issues, and the Room Key and Home Key program. And we also have calls planned on long-term recovery process and the effective use of social media before, during, and after emergencies. So we welcome your input on other calls. And again, they occur at this time, second Thursday of every month at 10:30. And if you happen to not be on the list, I'll post how you can sign up. So today, we welcome and have the honor of Sylvia Yee, who's the senior staff attorney at Redis, Disability Rights Education and Defense Fund. And Sylvia is one of our stellar advocates. I like to think of her that way in our community. And having worked with her for years, maybe decades, I have a huge amount of respect for Sylvia and her thoughtfulness and ability to analyze issues. So Sylvia's going to discuss the burning issues related to visitation, vaccination, and Valentine's during COVID-19. No, I don't have a clue about the Valentine's, but I'm sure we'll hear about that shortly. So, Sylvia, over to you.
Hi, Jane. Thank you for that introduction. I'm an Asian woman. I'm wearing glasses. My hair is growing as well, and so it's put up. I'm wearing a red plaid flannel because it's kind of cozy. It's a little cool, and I'm really not good at chopping wood. So putting this on makes me feel like I could chop wood if I had to. Let's see. I think we can. My plan is to go ahead and share some slides to have a brief presentation. Hopefully it will take no more than 20 minutes and then move into a discussion. I have been one of the people that's on the Community Vaccination Advisory Committee for California, It's a large committee. It started out with about 70 people and it's grown since then, um, to include more racial and ethnic representatives, some church representatives, and so on, to really be inclusive of the community. So it's close to, I think it's close to 90 voices, possibly over at this point. Um, I don't think being on the CVAC, as I'm going to call it, gives me necessarily lots of advance notice of things, but it does help me know the range of issues that California is facing. So since vaccination is one of the topics for today, um, it, it, it helps give me some window into what's happening with that battlefront, and it has become a battlefront in California for people with disabilities. So the first thing, we're looking at visitation and vaccination, and Valentine's is a surprise at the end, and it's mostly because I really like alliteration. So if we go to the first slide, one of the topics that has been an issue and a problem for really since the pandemic began for people with disabilities is visitation, and that's the right to have someone, your support person, with you in the hospital. So people with disabilities have the right, it is to reasonable modifications of generally applicable policies when needed for equal care. So that's the right on paper. It's a right that's in the Americans with Disabilities Act. It's in the Section 504 of the Rehabilitation Act, embedded in federal law, included in state law, the right to reasonable modifications. So with the pandemic, the general policy that most hospitals and facilities have put into place is no visitation. They're minimizing the number of people that can come into the facility because we have an infectious disease, and that's a logical, intelligent policy for facilities to have. What's at issue is the right of people with disabilities to have someone with them despite that policy. So we're saying that an individual with disabilities has a right to the assistance of support persons from whom they typically receive assistance. If this is someone who, with a developmental disability, with a variety of other disabilities, and they have someone, a family member, a paid support person, a friend who helps them function in their life, then they get to continue to have that despite the fact that a hospital or a facility now has this general policy of no visitors. The assistance given can be physical or related to communication or emotional. The support person can be paid or unpaid, a family member or a friend. And we have found that there have been issues with that, big issues across California, that people with disabilities have had to go to the hospital. Sometimes it's related to COVID, sometimes it isn't. And the support person they typically have with them, or the support a family member, a parent, a spouse, is stopped because it's COVID. There are no visitors. So it's the right on paper. And then the next slide has some of the issues that people have encountered, people with disabilities have encountered. So there have been a lot of, I think, anywhere from a security guard to often a nurse who's enforcing the blanket no visitor policy. Even when it's kicked up, you can have staff or supervisors not knowing their own facility's exceptions policy. Some of the complaints that we've heard have been from Kaiser, and this is even after Kaiser had a policy that recognized that minors, for example, minor children can have someone with them, that people with disabilities can have someone with them. Kaiser's own policy said that, but you would still encounter frontline staff who would just say, no, it's COVID. You can't have someone with you. There's a lot of finding that staff and supervisors don't know anything about how disability rights laws apply, or that civil rights and disability rights still apply even during a public health emergency. I think sometimes there's a perception that, oh, wait, it's a public health emergency, don't you know? Civil rights have been put into abeyance, which is not the case. And Another barrier is that potentially that a support person who could go in perhaps lacks personal protective equipment or knowledge to be able to comply with the facility rules. Because we would say that the person with disabilities has a right to have someone with them, a support person with them, but if the support person has COVID, or if the support person can't comply with infection control measures in the facility, that can interfere. That you don't necessarily have a right to have your support person do whatever the support person wants to do, and not comply with infection control. And we've also encountered time and task limits being placed on the support person. For example, a hospital might say, okay, your support person can be with you during regular visiting hours if they applied, but they have to leave at 8 every night, or they can't be with you at certain times, or they can't do certain things for you because our hospital staff are the ones who take care of that. So those are the various range of barriers that we've seen. And I have to be honest, it's been really difficult to deal with these, certainly on a timely basis. Sometimes if you're going to the hospital, it's 2 o'clock in the morning, and the nurse just looks at you and says, no, you can't come in. You can't bring your person with you. There is no immediate source of support for that. There is no lawyer on call who will be able to get on the phone and say, nurse, you're completely wrong. And here I also want to express sympathy for nurses and other other staff who are on the front line, because I think they're often caught, especially the nurse in some ways. They are not necessarily trained or given current knowledge about the hospital's procedures or changes in policies. They are expected to gatekeep, to keep hospital policies and to keep them going. Their supervisors or physicians might expect them to be keeping staff, keeping support people out. And at the same time, maybe they know that we're run off our feet. The ward is full. We're having to do so many extra things, change all the time between patients. I mean, it's been really tough for us. It might be great to have a support person in. I think a lot of nurses actually realize that support persons are extremely valuable, practically on the ward, and yet they're expected to keep this rule. So I'm not trying to rag on nurses. I recognize it's a tough job, but all that doesn't change the fact that often they're the ones on the front line and they're the ones saying no. When that happens outside of regular business hours, when you're alone, there's not an easy solution. There, as I said, there's no lawyer on call. There's no advocate who can come out and just explain, that this is the law. You have to comply. Civil rights applies. So what to do? There's the right on paper. There are the barriers you encounter. What can you actually do to advocate for yourself and to try to get around this? So, one thing is going in. You have copies of all the relevant documents that you can, which will include that hospital's visitation policy, if possible. You may not know which hospital you're going to, but if you do, like Kaiser's should be online. And I know they also sent out information on the visitation policy by email to their patients and members. So keep a copy of that. There's also the fact of the California Department of Public Health, which is in charge of all hospitals, has some guidance, important guidance on visitation policy. That's another thing you can print up and have with you. You can have relevant sections of the ADA or state law with you. Excuse me, my cat is having a breakdown. I have to take care of her or she's going to rip me up. My apologies for that. And she's panicking. Okay, maybe I can just do this. Okay, sorry about that. So the front line is to try to advocate for yourself as much as possible by having these things that you can concretely show them. And I think perhaps the hospital's own policy might be the most useful in a lot of cases. Bring numbers, bring the number of your own doctor, or any providers that can assist you with a regional center number, if a regional center employee there that helps you, or your IHSS social worker. And I know it can be really hard to get in touch with these individuals, even in the best of times, but it can be useful. Bring the numbers of disability rights attorneys. Find out who the hospital ADA coordinator is. Have that number with you. If you can find it, the legal counsel for the hospital, because at least the lawyer for the hospital should have some sense of potential liability for refusing to recognize your rights. So I know that's a lot of pre-research and a lot of work to have to do, but one of those things might be helpful when you're on the ground and there's no one around that you can call on for immediate help other than these things. And again, the 2 o'clock in the morning situation is always going to be hard. So if you're turned away, if you just can't, if they won't let you in, go away, regroup. There are places you can complain, and I've put some of those in the slide that I see an answer, and I will get to that. The Department of Fair Employment and Housing, despite its name, it does more than employment and housing. It's a state agency it's a civil rights state agency. And they should take your complaints. They should have jurisdiction over hospitals, all public accommodations, which is like all places that are open to the public. You can make a complaint there. There's also the newly created Bureau of Disability Rights. They're just part of the Civil Rights Enforcement section of the California Department of Justice. This is something that Attorney General Becerra set up just before he's the Secretary Designate of the federal HHS, and he's potentially moving, or he has moved. I'm trying to think if he's been, no, I don't think he's been confirmed yet. But in any event, he set that up, and that's a new place. Yes. And also there's a federal office, the Office for Civil Rights at HHS. And California has required hospitals to post their crisis standards of care policies. I'm not sure that they have also required hospitals to post their visitation policies, and that may be just me being behind, but I'm not sure that they've made this a clear pronouncement that hospitals have to do that. There is also the California Department of Public Health. As I said, they have jurisdiction over hospitals. They do have an enforcement section. They do take complaints. I have to say, we have submitted some complaints to them and have been disappointed with their response. In general, as a department, they consider their job is to make sure that hospitals comply with California hospitals law, with public health law. They don't seem to consider it their jurisdiction to enforce civil rights laws, even California civil rights laws, which has made it difficult to get them to move. I think if it's during the day, if you have a copy of the hospital's policies and they're not obeying their own policies, I would try to get through to the California Department of Public Health, because hospitals do pay attention to them. I would talk about imminent risk to your life if you don't get your support person, and that this is an emergency, and that they make some noise, see if you can get them to pay attention, because they are a bureau that hospitals actually pay some attention to. Okay. I just wanted to to make sure I have some of the questions looking at a government website. So that probably the best one, the California Department of Public Health should have on their site their visitation policy. So if you can pull that up and show it, that it's not, it isn't bad. It's a little bit, it's not as absolutely clear as it could be about um, the range of support persons that should be allowed. I mean, they recognize that people with intellectual and developmental disabilities can bring a support person, and they recognize you can bring a support person for communication. It's not one huge big statement that says people with disabilities can bring a support person, but still, pull it up. It can be useful. So that was Neil's question. Um, and I've been asked to talk more about the Bureau of Disability Rights in California Department of Justice. Yeah, that's as I don't know tons about it because it is new. I mean, I think the announcement for it literally came out 2 or 3 weeks ago. And they have been working, and they have some stories about the kinds of issues they've been working on. So they've been working, for example, on school stories, people with disabilities, and in that intersection of race and disability, students who have been getting suspended, issues at school, and they have some other ones. It's not just that they work in education; they are working broadly, and they do have jurisdiction over, again, any place that civil rights reaches, and civil rights clearly reaches hospitals and offices of healthcare providers. So in a way, it's a test, right? Excuse me. These are people who, at least these are lawyers and staff who should know, investigators who should know civil rights, who do know civil rights, and it's just clearly directing their attention to this context, to the COVID context in hospitals. So they need some complaints. Let's test them out. Some success stories. Sometimes it's easier to think about the horror stories, but I mean there have been some. I think I'm trying to think of ones where they're. I mean, Claudia, who's my directing attorney at Redis, is a hero to me in some ways. Someone reached her on a Saturday, got her phone number, and she found out she phoned and tried to get. This is the mother of an adult son with significant developmental disabilities and who was nonverbal. And the mother knows how his feeding tube works and how his trach works, and is so involved in his care, and they refused support, and she was refused her entrance. She spent the night just incredibly anxious that her son could be dying, right? She just had no idea. I actually don't think he was in there for COVID. He was in there for other reasons, and they refused to let her in. So the success story, she managed to reach Claudia on a weekend. Claudia got through eventually to their legal counsel and convinced them that they needed to let the mom in. And she went in, kept him alive, and actually has found that the nurses and the whole have come to acknowledge how helpful she is. So once that's happened, then next time, if there is a next time that a person with disability has to go back to the hospital, there is some easier acceptance. If there's someone there who recognizes that, oh, it was great to have you there helping, then that's an ally inside who can help explain why you need to be there, and why the person with a disability needs a support person. It's getting that first foot in the door, and it's too easy to for them just to say no. And I've seen people sort of change their minds too. I think the sense at the beginning is that if you're doing all these things like cleaning the trach and doing and getting the ventilation set up, I mean, that's what the nurses are supposed to do in the hospital. I don't know why you think you need to be there. And they can be advocating, that the hospital can even advocate for more invasive things. It's like, oh, we can't get the patient to eat. We would like to put in a feeding tube, as opposed to, well, a support person can say, I could get them to eat if I were there, right? It's sometimes it's so clear the difference it would make, and a hospital won't necessarily see it. So yeah, so having a concrete list of all the ways you can help. I mean, sometimes the approach is right. This is my right to have someone with me, and there's that. But there's also the approach of this person will do all these things that you don't have to do then, that the hospital is not, this is, and that's clearly a softer approach. And as a lawyer, I don't like soft approaches. I like to be able to go, this is my rights, but sometimes you do what you need to do to get the person, to get what you need. So that's okay. So I think with that, I'm probably going to be switching over to vaccination. So the CVAC, the Community Vaccination Advisory Committee in California is one of two committees that the state set up. The second committee is the Draft Guidelines Working Group, who is filled mostly with doctors. I think they're all doctors, epidemiologists, pediatricians, etc. And they're the ones who are actually drafting the guidelines for the state about who the vaccination order. And we've been meeting for the CVAC has been meeting for several weeks now, recognizing that there would not be enough vaccines to vaccinate everyone in California, that there would have to be some kind of order. And I think that the first tier of frontline healthcare workers, the people in hospitals, the people driving the emergency vehicles, etc. That first tier included frontline healthcare workers and people in long-term care situations, because there wasn't too much argument about that. Recognizing how many people have been dying in nursing homes, recognizing that we need to keep our healthcare workers functioning. So that was the very first tier, and that is I can't remember the exact numbers, a few million, actually. I think that's where the first vaccinations went, since the vaccines came in mid-December. So this next tier, we worked out. The state proposed some tiers, 1B, the 1B category, which had two tiers, and then a 1C category, which is the first place where people with disabilities and underlying conditions were mentioned. And then about 2 weeks ago, there was what I call the great upending, when Governor Newsom had a press conference and basically said, we're going to include for vaccination everyone over 65, and moving forward, we will have an age-based framework. So that did upend everything, because where did people with disabilities and underlying conditions below 65 fit in this framework? Where did we fit moving forward? So right now, the situation is that California is officially recognizing for vaccination frontline healthcare workers, which should include support persons and family caregivers. I think there have been constant attempts to make that clear, gradually getting clearer, but I also still hear stories of refusals at vaccination centers. But they are supposed to be there. Right now, California is also recognizing long-term care personnel and residents, people over 65, some essential workers, and the categories are food and agricultural workers, emergency personnel, and teachers in childcare. So that's the sort of the official line. And ever since then, I think people, disability advocates, community advocates, people with disabilities have been pushing for clarification and for inclusion of people with high-risk disabilities and underlying health conditions. So we can move on to the next slide. So there have been lots of issues with actual implementation of this. You have the official category, and that's one thing, right? And then you have what's actually happening on the ground. And there's been a considerable confusion and discrepancy. A lot of that is because from the beginning, the state said, we'll have these guidelines, we'll put out the vaccines, and then there's county and local discretion about how to actually implement the guidelines. So that has meant that a lot of I think most of the bigger counties have set up some kind of committee or some group to think about, well, what do we do? Who do we reach first? How are we actually going to set up the vaccination centers? We know that there has been inaccessible outreach in print letters, period. Outreach in English, period. Or maybe English and Spanish, maybe. There have been inaccessible appointment systems, so that a lot of this has been online, which automatically doesn't reach a lot of people who don't have online access. That includes older people, that includes people with disabilities, that includes low-income people of color. There have been inaccessible vaccine sites and inaccessible follow-up information. I heard an aging advocate tell me about an elderly Asian woman, didn't speak English very well, got her first shot, and was given directions for the follow-up shot in English, which she didn't understand, and didn't get her second shot because she didn't even realize exactly when that was supposed to happen or that she needed it. There have been few or no accommodations or modifications. There's been a lot of inequitable operationalization, not just in California, but across the country. For example, we are hearing the federal CDC vaccination group has been saying that 90% of those over 65 who have been getting shots have been white. And that's a hard figure to hear when you also know how many black and brown people have been dying of COVID. And there's still no infrastructure yet that I know of for house call vaccination, which is essential for some of those over 65 with disabilities as well as people with disabilities. So that's just a snapshot of some of the problems. One thing, though, about local discretion is that I think in some places, some people with disabilities who are at risk have been able to get some shots. And that's been, that's confusing as well to hear. Some of that has been, if you're plugged in with your provider in some way, because the shots are ones that have to be used quickly. It's at the end of a day, at some point, there are always going to be the vial has been punctured. Every shot in there has to be used within 6 hours. And there's always going to be some kind of like urgent situation where being in the right place at the right time, knowing the right person might enable you to get a shot. And that may offend our feeling of like what's fair, but that has allowed some people with disabilities to come in. I have heard that some support people have been able to go, they drive in their car to a vaccination site and they have the person they provide care to in the car. Sometimes the vaccinator just does everyone in the car, recognizing that the person with a disability is at high risk. But that's really hard to deal with. It can't be no one is always at the right place at the right time. You can't have an entire group of people, like people with disabilities, waiting for these little backdoor opportunities. Yes, I see a question there. I'm going to just try and answer questions sometimes as they come up too. So the Bruce had the question, what is their excuse for the lack of these plans? We have been talking about all of these issues since our first COVID meeting with the state. Vance was all those calls with most of us. Yes. I think for the state, there has been a more recent recognition that honestly, California's public health system has been sort of starved of funds for a long time. We don't have the infrastructure that could just take a directive from the governor from on high. Here are some vaccines. Vaccinate everyone equitably. We don't have the infrastructure or the people or the resources for that just to be implemented like that. Um, yes, we've been talking about that, about equity and about putting some plans in place. But then we're also, people with disabilities haven't been recognized in the priority system yet. We still aren't. There's no official record. 1C is gone, as far as I know, and there's the richest state in the country. It's one of them. We also have a whole lot of people. I think about, I'm from Canada, um, and I think about California having roughly the same population as all of Canada. And logistically, that kind of planning, that kind of implementation is hard. I I'm acknowledging that it's extremely hard. I do think that it has to begin with an official recognition in the priorities of people with disabilities. They have to be in the priorities. And then we've approached them with lots and lots and lots of implementation plans and thoughts. Oh yes, a question here also about anything about caregivers refusing to get vaccinated. Um, there's been quite a lot of study and looking at that. I think the overall rate for frontline healthcare workers is 40% refusal. You can say refusal or delay. I think it's important to recognize that for a number of these people, it isn't so much a blanket. I don't believe in vaccination. I will never get vaccinated. It's more of a, this is really, really new, and I'm not sure I want to do this yet. I, I don't know the impact yet, and I just want to wait. Some of the factors, it seems like um, the frontline physicians have been more likely to get vaccinated, going down education levels and other factors, income levels have sometimes affected the hesitancy rate. Um, so there's been less openness to be vaccinated amongst some groups, and I think caregivers support people might be among them. I recently had someone say that she didn't like the term vaccine hesitancy because she thought it was judgmental. So she's trying to use vaccine openness. So I thought I would try to follow in that a little bit. Um, from June, asking me if I know of any local models, programs, or mobile home delivery or house calls of vaccination administration is happening. I, I'm trying to distinguish between, I do think there are counties where mobile vaccination is happening. And most of the time when they talk about that, they mean vaccination is being brought out in a van or some unit that can set up in a particular zip code or in a particular area to be more readily accessible to the individuals who live in that neighborhood and that zip code. And that is important. I think that's absolutely clear. That's important given changes in public transportation and everything. Vaccines need to be brought to where people are, and especially low income people of color. Um, I still distinguish that from the house call vaccination. I don't know anywhere that's happening yet. I've heard reputedly. I've heard some counties that have said we're ready to do that. We're ready to implement that. Um, Honestly, it's a challenge as well with these vaccines, which need sub-zero, and then they're brought out of sub-zero, and they're okay at refrigerator temperatures for a little while, but then the puncture, as I said, the seal is punctured, you have 6 hours. So if you go into someone's home, you could get the people in that home, and then you need to wait around a little to make sure there's no allergic reaction, and then you go to the next home, right? And it has to be really planned well, and people have to be ready to take the vaccine. Um, and that level of sort of planning, I don't know that anyone has dug down deep into it. The Johnson and Johnson vaccine, which is Johnson and Johnson submitted for emergency use authorization for that, and the federal approval authority is meeting on February 26th. That one holds a lot of hope because it only needs regular refrigeration temperatures, and it's only one dose, not 2 doses. There are a lot of things about it that make it more logistically convenient and sensible for home delivery. But we're not going to get it, even if it passes. It's not going to be out until like March, early March. But honestly, vaccination in early March looks pretty good at this point because people with disabilities not being on the list means that people with disabilities are potentially looking at June for vaccination, first dose. So I'll go on to the next slide, I think, which is like, what can you do? This is a hard one for me to write, because it's like, well, what can you do? What can you do to actually? Here's the difference between local. I mean, you might be able to find, or you might be fortunate enough to live in a county where they're finding ways to vaccinate people at high risk, people with disabilities, younger. And when I say people with disabilities, I mean the ones under 65. Because if you're over 65, they're not going to stop you, whether you have disabilities or don't have disabilities. You can get to a site, you show your driver's license or your ID, and you show your age, your birth certificate, you should be able to get a vaccination. Though there's still, of course, the issues of getting an appointment, getting that, like, you still have to navigate the system, which is not a difficult system, but you wouldn't be turned away. Right now, younger people with disabilities, no matter what their risk is, can be just turned away because they're not on the list. There is no recognition of people with disabilities below 65 on the list, no matter how many comorbidities you have, no matter how clearly you are at risk of medical triage, of medical rationing. It's all irrelevant because the list is there and younger people with disabilities aren't on it. So for this, it's contact Governor Newsom, agitate with HHS Secretary Galley, write, email, call. That's sign. There's some letters that are going around, some petitions, sign those. Share and publicize the vaccine needs of people at high risk from COVID-19. And we want this to be broad and inclusive. We've talked, those of us who are on the CVAC, which includes Andy Imperato at Disability Rights California, includes Christina Mills at CFILC, it includes Aaron Carruthers at the State Council of Developmental Disabilities, and Denny Chan at Justice and Aging has been a great ally. We've been working really, really hard to try to float these ideas of, okay, here are some high risk, some people with disabilities who are younger that we know are at high risk. Look at IHSS and regional center consumers. IHSS consumers because they have to have people coming into their homes, support persons. They can't just shelter in place and have everything brought to them and not worry. Well, I mean, you can worry anyway. I don't mean to be flip, but if you have to have someone come into your home to help you get up in the morning, to dress, to bathe, to eat, that you can't socially distance from that support person. And you have to have that support person to live. So this is increased exposure. That support person could or could not be vaccinated. And even if they were, we don't know that vaccination means you can't carry the virus. That was one of the shortcuts. I mean, in the race to get these vaccines done, we know they protect someone who's vaccinated from getting COVID. We don't know that they stop the vaccinated person from passing on COVID. So that's an important point as well. So there's greater exposure. IHSS recipients have an average of 4.2 comorbidities. Many have mobility disabilities. And so this is a group that is vulnerable by any measure. And 70% of IHSS consumers are people of color. That's also true of regional center consumers. 70% are people of color. So if you're looking at all, and they're low income, they're on Medi-Cal. So this is where a confluence of a lot of factors, that these are people you should be looking at, that you should be targeting for vaccination because they are vulnerable. And there are already people who have been medically evaluated as having disabilities. So you don't need a new, fresh doctor's note that they have comorbidities. So we've been fighting a lot for this group. We've been fighting also for people with health conditions who are on and off the CDC list of comorbidities. So the Centers for Disease Control has a list of comorbidities, which is health conditions that are associated with severe COVID. So that if these people catch COVID, they are more likely to die or be severely impacted, have a severe case. CDC has two lists. A list of that's true for these conditions mean that it's likely they'll have more severe illness, and then a list of might. These conditions, these people might be at risk of severe illness. I feel strongly that the list is under-inclusive for a number of reasons, but one of them is that that's just how research works. They look at the more prevalent a condition is in the population, the more likely the research is going to be done. The more people you have that have both that condition and COVID. So for instance, diabetes type 2 is on the first list of CDC. Diabetes type 1 is on the second list, the one that might lead to severe illness from COVID. And I think that's because type 1 is much rarer in the population. 5% of people with diabetes have type 1. So you don't have the research done. You don't have the findings to support this peer-reviewed study. And that's not what the CDC list was there for in the first place. It's not there to be a gatekeeper for vaccination. It's just a list that was put together to help doctors know who's at risk. So we feel strongly that people with disabilities who have high-risk conditions should be recognized. And then there are people who have foregone needed healthcare and treatments because of COVID-19 and or medical rationing. And we just heard a story yesterday about someone with HIV/AIDS who was extremely fearful of the impact of COVID if he were to catch it, who was afraid of medical rationing, and who was foregoing a lot of regular treatments that he would get typically at a facility. And so his condition worsened. He had a lot of opportunistic infections, and eventually he died. And the cause of death on the death certificate might be HIV/AIDS, but it is COVID just as much. There was a chat question, let me get to that. Are you, from June, are you aware of local programs where there has been inclusion of some of the high-risk disability priorities? I think that Marin may be one of the ones that has, where the local council has perhaps, the local public health council has come to recognize the needs of people with high risk disabilities. There are a few others, possibly Sacramento. I'm sorry, I don't remember the specific ones to name them. If I went back on email, I might find some. But I will say that when Governor Newsom had the great upending a couple of weeks ago, he also seemed to indicate that there would be more centralized control, an attempt to have greater control over what local authorities were doing. I'm not sure how that's really filtered down, if that's true. I believe that the state guidelines should be a floor. That is, you can't refuse to vaccinate people who are recognized in the state guidelines. If, as a local authority, you have some more, you're doing pretty well on your allocations, you have vaccines that you can give out, you have a location that's slow on the vaccination, you should be able to recognize others, such as people with high-risk conditions. That would be my approach to that. Um, let's see. We are at the one of the last slides, I think. Going on. What can be done? Okay. This is my Valentine's, which may seem really silly, but it has been extremely stressful. It's been a whole stressful year for people with disabilities, and for the past few weeks with the vaccination, I hear stories about people with disabilities who have died in the last 1 or 2 months. And I think to have had that hope appear on the horizon, the vaccines appear to offer hope to everyone, and yet to have not been able to hang on is appalling to me, and to not be recognized. So my Valentine's is that we need to take care of one another and ourselves. It's easy to forget about that sometimes. In the need for work, we are surrounded by people who are facing injustice, who are having their civil rights not recognized, who are fearful, so fearful of not being recognized for vaccination. It's hard to think sometimes, how do I take care of myself? But you have to. You have to think of the things you need, and sometimes it's just sleep and food, and sometimes it's like getting outside for a walk or a roll, and sometimes it's just spending time with people you love and being on the phone with them. As simple as that. Help your caregivers get what they need to feel comfortable with vaccination. I mean, talk to them about it, and there may be some real reasons they just are wanting to wait. I think that frank discussion is important. Form alliances that acknowledge all our intersectional characteristics and identities. And during this time, and being on the CVAC committee, that lots of community representatives on there from lots of different fields, and more than ever, I recognize how all of us, in the fullness of who we are, combine so many things: race, ethnicity, sexual orientation, gender identity. We've formed a really.
I heard understand Spanish. I understand some of it. I grew up in California. I can, if I listen really hard.
Oh, oh, well, thank you for that. Yeah, I think it's really important to be able to do that and to dig into that, to recognize that we can make connections with one another that strengthen us. I know it just seems like such an idealistic and silly thing to say, but I think it's important. And to be, we absolutely are stronger together in fighting for this, in fighting for justice in how the vaccination is rolling out. And so many of us are just caught in it, but we can comfort one another, and we can keep on pushing. So that's my little Valentine slide. I think we can go on to a broader discussion and questions now, and my contact information is on there.
Hey, Sylvia June, thank you. Wow, that was almost an hour of you being.
I'm so sorry.
No. I was going to compliment you. You fielded the questions. You did really well. We didn't have to do anything. Good for you. So you all listeners, you're good. So continue to use chat, or
Yes.
in the participant list, there's a way to raise your hand if you rather voice your question. So I know there's probably a lot more questions that will come up. And so Sylvia, you're really good at voicing the questions in chat. So I'll start off with one thing you said. You said CDC has two lists. One of people who they feel, and maybe their data, who are definitely at risk, and then those who might be at risk.
Right.
I noticed one of the categories was neurological conditions. Now that to me seems like a huge bucket. Can you comment on that?
Well, I think, I mean, they're just going on, it's almost like the whim of research, right? It's what has caught providers and medical researchers' attentions, and often it is really sort of indeterminate. You begin a research. Some of it is very, very specific, right? Oh, it's this specific condition. We think it's allied, and others are like neurological conditions. Or, the world of medical research is arcane, I think, and the double-blind trials and the kind of recruitment that has to go on. And I just think it's really hard to get sufficient research. I mean, for example, I think in the last month we've seen increasing studies that talk about people with intellectual and developmental disabilities being at 4 to 6 times the risk of others in their age group of severe illness from COVID. Right now, the CDC list just has Down syndrome on the first CDC list, because they haven't updated for a little while, since late December, I think, and maybe it'll update for that. And very recently, we saw a study about people with schizophrenia having a higher risk. As well, severe consequences from illness. So all of this, like how much research is needed to get on the CDC list? How often is it updated? I think the main thing is that it's a bit of a double-edged sword that they have it at all, because I do think it's under-inclusive. It can't be the only list. But at the same time, the fact that it's there can help some people. So, for instance, fat advocates that we know of, obesity and morbid obesity are on the list. Fat advocates hate those words, but there it is as a condition. And it is, I think it is true that many people who are higher weight have died from COVID. Some of that may be medical triage and rationing, frankly. But it's there, and it's an easier way to allow those individuals at least to prove that they are at high risk. So we have this three-pronged approach. We want IHSS recipients recognized. We want developmental disabilities, people with developmental disabilities recognized. And we also want there to be a safety valve, something that allows people with disabilities, people with high-risk conditions to say, in conjunction with a healthcare provider of some form, we want that to be broad, to say, look, I'm at risk, and this is the risk that I'm under, and I need vaccination now. And that third prong can benefit from the CDC list, and it can be hurt by the CDC list. I'm going to answer a couple of the questions or not answer, just raise them for discussion, because I don't have the answers. Vince Lopez asked, is there any way to cut off caregiver pay until caregivers get vaccinated? And monetization really influences people's decisions. I can recognize that, but at the same time, I also have some trouble with that. I think there are there actually are some individuals who may have valid reasons for not getting vaccinated yet. Some may be health related or not. And it is, I just think it's better for people to come to the realization that they need to be vaccinated and to want it themselves. There are going to be some who fight it, and the lawyer side of me is really wary as well about employers being able to force that kind of thing on their employees, because that can be broadened broadly. And if you have all kinds of employers forcing their employees, including employees with disabilities, to get vaccinated as a condition of employment or pay, um, I think that is a consequence we need to be very, very careful of. That's that's not an official dreaded position. It's my thinking on this. Were there thoughts from anyone else on that? Okay. Um,
Yael has her hand up. Go ahead. Yeah.
I have a couple of questions. One is, how do they, most people with disabilities generally have more than one. And so what happens when there's multiple disabilities, and um, how do they, that may or may not fit into certain lists? And then I'm really concerned about disabilities that are more rare, but their
yeah,
risk is high.
absolutely. I that's one of the things I see, a problem with the CDC list as well. If you have a rare disability, they're never going to be researching you until years down the road. They're not going to be looking at this. Also, people with just idiopathic, unusual. I mean, there are lots of, we tend to think medical science is so established, but there are still people who are experiencing significant disabilities, functional limitations, etc., and who don't have a diagnosis, right? Some official diagnosis that they
Exactly.
can come forward, and so that's very problematic for the CDC list. There has been there's an organization, Fair Health, that looks at somehow they have access to a whole bunch of private hospital billings and coverage decisions. So they actually looked at the impact of comorbidities, and we've used this in our research and argued this with the state. And they found that the more comorbidities an individual has, uh, the more likely they are to get severe COVID. So, for example, someone in in the 45 to 65 age group with, I think it was three or more comorbidities, four or more comorbidities, is in the same has the same risk as someone who's 75, or sorry, someone who's 65 plus. Right? So if that risk is the same, then you need to expand. If you've decided that I need to, as a state, we need to recognize a high risk that people who are over 65 have in the community, then you also need to recognize those who are below 65 who have that same level of risk. So that's something we've used. The research is on the DREDF website. Um, I can give the exact link to Megan. If there's discussion, I can send it over. But Dr. Steve Kay, who's a professor emeritus at UCSF and who's a DREDF board member, just did a great job doing some of this research for us and pulling up some of the comparisons and trying to show that younger people with disabilities have high risk levels and need to be recognized for vaccination.
May I ask one more question, please?
Yes, of course.
Do you know if they're studying, or if there's any studies out about um, the the reaction to medications, or the interaction of various medications?
Yeah, with a vaccination, with a vaccine.
Yeah.
Yeah, we've asked about that. We actually had a session with a couple of the California doctors not recent. It was probably over a month ago, and the basic answer is no one knows. In this, you know, in this fight to get out the vaccines and these battles over prioritizations, some of the research which we really think should be done is not necessarily being done right now, and that's one of them. I think probably prioritization for research right now is on adolescents, people under 16, people under 18, because they weren't included in the original testing of the vaccines. So there's lots of questions about that. They are researching the impact of the vaccines on pregnant women. Lots of questions about that. I don't know that they've gone down to the level of researching the impact of the vaccines with specific medications, and I would think that's probably is really needed, and especially important around some of um, the some of like depression meds, mental health meds, because there a lot of that. There's a lot of depression and mental health issues out in the world right now. Certainly in the U.S., a lot of meds being used, and it'd be great to have some of those answers. But I think right now we do not.
Some countries are doing that, which is amazing.
Yeah,
Yeah.
that's good. I mean, I think they're. I don't think it's necessarily happening in the U.S. I don't think it has to happen in the U.S. Right? Because I think people are sharing. Countries are sharing their research.
Mhm.
So we'll just have to keep marching forward with that. Yeah, I'm sorry I don't have a better answer for that. But, um,
Thank you.
Neil Jacobson had the question of we should not have to prove our. It might be just a comment, which is great. We should not have to prove our need for our attendance. There should be a simple statement stating that people with disabilities who say they need their attendance have the right to do so. Healthcare facility may have a form that we sign. Yes, I recognize that, and it's 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 hard because it does really seem like how do I put this? I'm not sure of, let's say, the degree to which someone who shows up has to prove their occupation, for example, or the segment they work in. So if someone shows up and says, "I'm a fireman," do they have to prove that? I don't know. It seems that some of it is happening probably on work sites, let's say. So if for teachers, if vaccines are being distributed through a school system, then okay, I expect that probably only the teachers are getting that because the school system knows who's working for them. Right? For some of these others, I'm not sure, and it is troubling that then it comes down to people with disabilities, and there's this level of hmm. I think you need to prove yourself. Get your doctor's note, right? Get your. We're trying to think of ways to make it as simple as possible for IHSS and regional center recipients and clients, because there should be ways to simplify that. But for the person in the community who receives home and community-based services, not like private pay, let's say, um, yeah, there's not necessarily going to be a shortcut, and there is going to be this level of proof, which I know is troubling, and I wish it were not there. I'm not sure that we're going to be able to fight for it to just not be, that. And here is where probably if you have a clear, visible disability, you might be more fortunate with that. If you have the invisible disability, it's going to be a battle to try to get in for vaccination without any kind of medical verification. Um,
Hey, Sylvia, it's June. You've given us a lot of really interesting statistics today about, co-occurring conditions and increased risk, 70%, and some of those other stats you quoted. Are they all on that Redis section of your website that Steve K put up? Because you mentioned quite a few that will be really helpful for us to use in our local advocacy.
right. I'm copying the link right now to put it into the chat. Um, uh, Let me just do that. I have trouble multitasking, obviously.
Yeah, well, while you do that, I'll take the pressure off and remind people that, because I have trouble doing that too, but we want to make sure you notice there's a feedback link in chat, because we learn a lot from you about if these calls are helpful, what we can do better, what we need to rethink. And it also helps us to kind of justify the value of the calls to future funders. So it's a real painless survey. It's really quick. I think there are only 4 questions. So please hit the link and take the survey before we finish today. And I'll also put it on the list later on today in a nag and nudge note for you. So
okay, that's great. Bruce, you had a comment in there, and it was what kind of logic says that a 30-year-old healthy teacher needs the vaccine before a person with a disability who has serious health issues? Yes, and I understand that question. I mean, one thing about the vaccination process and this, they said speed. We have to get out the vaccines, and so they're not. It's not an individualized assessment, right? It's not like there really isn't the time for that. For someone to come up and they go through, okay, your exposure level, your occupation, your personal health, who you live with. I mean, all of those, where you live, um, all of those things are relevant, but they're not doing that. And I have to say, they probably can't. I think that would be unworkable to have every single person get an individualized assessment. I think it was just a look at the sector, and they were looking at education. And one thing, because Jredif works in special ed as well, one thing that the pandemic has really exposed very clearly is the degree to which our society has more and more and more come to rely on schools to provide all kinds of things, not just education, but food and social supports. And it has become a catch-all. And for so many low-income parents as well, it is childcare. I mean, you might want to say, no, it's education, it's not childcare. But as we've seen, families and lots of our economy sort of grind to a halt because kids aren't going to school, and the pressure on moms in particular. And I acknowledge dads fully too, but especially moms with younger kids who are working is tremendous. And I'm only raising this. I'm not saying it because it speaks against your point, because I absolutely know that the person with disabilities is at great risk and needs vaccination. But I also want to say that as a sector, the degree to which education, public education, is critical to our society being able to move has really become apparent over this past year. And people have said it with things like teachers need better pay and all this, but like a lot is put on the shoulders of education. And I think when the pandemic is over, we need to think a lot more about what that means for all of us.
oh yeah, Al, your hand is still up. Did you not put it down, or did you have another question?
Actually, I have a quick comment. I just wanted to give a shout out to the paratransit system in LA County. Access Services is working on a way to have Access Services be able to take people to a vaccination center, the bigger centers, and be able to get them in and out on an access van using paratransit. And I think once people with disabilities are more able to access that, there'll be a system in place with at least with transportation. And I think that's fantastic. And that's really, we need to see more of that in our communities, those kinds of ingenuities.
Right.
Hey, thank you for sharing that. We've been looking at that kind of model for a while, so hopefully it'll be replicated in other counties if LA access services could lead the way, because that's huge.
Yeah, I would. Oh, I'd love to hear these. Yeah, your ideas and what you've been seeing are I would love to hear them so we can carry them forward. I've also heard of some people suggesting that paratransit services perhaps be used for reverse transportation, for carrying providers with vaccines to people in the community who actually can't leave their homes. It's just another thought. June has a question here. While the state continues to deal with a high-risk disability priority question, the important advocacy activities appear to be at the local level. Can you comment on what the impact of the state guidance regarding disability clarification and inclusion as a priority may be, if and when it is released? I think that it's still important to have the official prioritization and inclusion of people with disabilities to stop the degree to which there's just turning away. Because if you're not on there, if people with disabilities aren't on there, it's you can't even properly complain about a vaccination center turning you away because you weren't supposed to have a place to begin with, right? And it also will help on the local level. I mean, there are lots of individuals with disabilities who are on their local county vaccination board or fighting at that level, and they can amplify that. They can say, look, here it is, the state guidelines. What are you doing about it? You know, how come you keep on saying, I think all these advocates have been getting a lot of, we hear you. So, okay, thank you for hearing me, but I'd like you to do something now. And now the state says you have to.
Thanks, Sylvia. That's helpful to me anyways. Hey, Dan, you had a question.
Hi there. Yeah, thank you. Yeah, for those who don't know me, I'm Dan Oakenfuss. I'm the new public policy manager for CFILC, just started last month. I come from the state capitol and the legislature, and one of the best things we do to hold the administration's feet to the fire is to raise our concerns with the state legislature and our elected assembly members and senators. Yesterday, there was a joint oversight hearing in the Capitol hosted by the Assembly Accountability and Administrative Review Committee and the Assembly Emergency Management Committee. And there was an opportunity for public comment, and Russell from our office, myself, we were there listening in and were able to raise some concerns. There were some members of the committees that did raise the prioritization issues to the state panel. And on the state panel was Dr. Erdogan, Director of DPH, and Yolanda Richardson, Secretary, California Government Operations Agency, among others. So it was kind of a great example of how we can, do a lot of mobilizing and sharing our concerns with our elected officials, and they can then in turn have those great questions and analysis for administrators as we talk about the complications of the vaccine rollout. So just wanted to add my 2 cents, and we'll continue to keep watching for opportunities like that again in the future.
Thanks, Dan.
Sylvia, can you comment on Andy Imparato, our own Andy Imparato's from California Disability Rights appointment to the Biden Vaccine Equity Council or committee or advisory group or whatever?
Right. I think it is a great thing, and I think one of the reasons it's a great thing is because he's been steeped in California's battle. Right, so he's bringing to it an understanding of what's happening in the state. He's been hearing a lot of what's from Christina and others about what's happening at the local levels. I think he does have a good, strong understanding of how and why people with disabilities, various disabilities beyond the CDC list, are at high risk from COVID. He has a good understanding of how the risk of medical rationing, how crisis standards of care apply to people with disabilities, how that's related to vaccination. And I think you can bring all of that to the federal vaccination issues. And it'll be interesting to see how this will work. I mean, a lot of the mess we're in has been because of a lack of federal leadership. We all, you can recognize that right from the very beginning. And I know there is limited jurisdiction in some ways to the feds, and local is really important. Local is especially really important for equity reasons, implementation of race, disability, LGBTQ equity, right? But still, a lot can happen federally. A lot can happen because purse strings are federal, and implementation strategies and sharing of good practices can be federal. So I'm hopeful that this will be a good thing moving forward. I'm glad that they included someone with a disability. Andy is pretty open about being someone who is bipolar, and so he carries that understanding with him. That's important.
Good points. Dan, back to you for a second. Your comment about the hearings. Can you make that more of a direct connect point? What might be the expectation of the legislature in terms of those hearings or their ability to act in any quick kind of way? Can you help us understand that a bit more?
Certainly. That was just a opportunity that I noticed in the Daily File, which is the Capitol's publication of events and hearings. They announced it last week, and it was just simply an oversight hearing involving these two assembly committees, just analyzing the governor's COVID-19 vaccine distribution. So these pop up a lot during the early parts of the legislative year before these committees get occupied with reviewing individual bills and individual budget items. So it popped up on our radar, and so yeah, we prepared some talking points, and we were able to kind of share those with the committee members about our concerns with people with disabilities being in lower priority.
Mm.
So what I want to echo is that it's not just these hearings too, but and Russell and I are working on that too as well, how we can engage our local members with their individual assembly members and senators too, and can keep this issue alive.
Good point. Good point. Well, I don't see any more hands raised, or Sylvia, I don't see any more comments here in chat, but hey, before we end, I wanted to really congratulate you. Usually these calls are panels, but you did your own marathon in a really excellent way. I mean, I'm impressed, and thank you for sharing some really great content. You covered a lot of really critical waterfront issues in the space, and I want to really thank you for doing this on your own and being so good at it. So thank you very much.
Thank you for having me. Thank you, Megan, for the slides, and thank you all of you. I mean, because I really wanted a conversation, and your questions, and your knowledge of what's happening on the ground is really great to hear.
Yeah, so thanks again to all of you. We will be having, I think Russell is putting together another call on the fourth Tuesday of the month. Some of these issues we'll be able to dive into even more in terms of more of an open discussion with some people addressing some of the FEMA issues and other issues. So, Russell, did you want to take a minute to comment on that at all? You're on mute. Oh, well, okay. Well, I think I covered it. But thanks again, all of you, and fill out the evaluation for us, please, please, please. And thanks to you, Megan, for keeping us unbombed. No Zoom bombers today. It was great, and helping us get this organized. So thank you all for your really good questions. Really nice high-level discussion. Good to see some of my friends on here too. So thanks again, and hopefully you'll join us in another 2 weeks.